Alright guys, chapter 35, chest trauma. Let's move on. Introduction. Annually, thoracic trauma. It accounts for about 700,000 plus emergency department visits. About 18,000 of those result in death. In 2015, in the National Trauma Data Bank, we found numbers of about 183,813 traumatic incidences involving the thoracic region. So an estimated 1 in 4 trauma deaths are directly related to thoracic injuries. And a lot of that's because of the specific organs that are housed within the thoracic cavity, as well as the mechanism that causes these injuries often involves a great force. So as always, we're not going to go over much about this because you guys have just done this. So it's important to remember that the primary physiologic functions are maintain oxygenation and ventilation, and of course circulation as well. Let's see, blunt trauma. So we'll go on down. Thoracic trauma may impair cardiac output. Obviously, it's going to mess up the pump. So it's going to start, having some issues, which when you start to impair cardiac output, then you also start to potentially mess with the perfusion of vital organs. So with pathophysiology still in this chest trauma, thinking about ventilatory impairments can be fatal, and the reason that is patients with chest pain, typically they breathe shallow. So that's going to start changing a lot of O2 onloading, CO2 offloading, just a lot of different things. It starts reducing their minute volume, which we've talked about, the minute volume. So basically just that volume of air exchanged in 1 minute. Air entering pleural space compresses the lungs and decreases the tidal volume. That's not good. So, when we start having pneumos, whether they're just a pneumo or an open or even a tension, then all that pressure in there starts compressing on the lungs, as well as blood collection in that cavity as well will start to affect lung expansion. Atelectasis, those collapsed alveoli, that starts messing up with some gas exchange, as you can imagine. So scene size up. Got to make sure, as always, it's safe. After identifying the number of patients, triage them, determine mechanism of injury. General impression, so assessing their LOC, sick or not sick, like we've talked about. Responsive patients may give you their chief complaint. They may be able to tell you that, what's going on. Difficulty speaking may indicate that they have a chest injury. So we want to pay attention to everything, assess the entire body. So we want to look for injuries. We want to look for an appearance of blood. Obviously, considering we're talking about the thoracic cavity with the lungs and the respiratory system, we might look for difficulty breathing, cyanosis, irregular breathing, chest rise and fall equally, all those kind of things. You also see, we'll look on the neck for some accessory muscle, as well as some JVD. So the thing we're going to do is we're going to focus on the ABCs, or CAB for the patient who's in full rest. Assess while performing spinal immobilization. So patients with significant chest injuries will appear sick and frightened or anxious. When people get a lot of air hunger, oxygen deprivation basically going on, then it will make them a little bit anxious, obviously, as well as they could have poor color because of the lack of perfusion. So that's one thing to think about. And once we got to get those clothes off so we don't get tricked and we don't miss things. It's important. So, as always, we need to respect the patient. And when we do that patient assessment, as we always say, we're going to make sure that we use that systematic approach. So we'll palpate the neck, checking for some tracheal deviation, inspect the jugular veins, seeing if they're maybe noted or even if they're flat. begin our thorax inspection by checking for contour, appearance, symmetry of the chest wall. So some of the other things that kind of suggest an underlying injury that could potentially compromise breathing, signs of soft tissue injury within the thoracic cavity. So contusions, abrasions, obviously probably just decap BTLS. It's going to cover everything. Paradoxical motion, remember that's one-sided motion. So whenever one side goes up, the other one goes down. Retractions, subcu air or even edema, impaled objects, penetrating objects. So, we want to start looking for all of these things. Oops, I was already a little ahead. So, address our life threats that we talked about. Assess the ventilation and oxygenation. So we want to look for a couple of different things. We want to look for the respiratory rate. We want to look for the depth. We definitely want to look for the effort. Look to find out if there's any reliance on accessory muscles. Look to see if we notice any cyanosis or if even an altered mental status, which could suggest, poor oxygenation. So we want to apply O2, non-rebreather mask at 15. We want to provide positive pressure ventilations with 100% if inadequate breathing. And then decreasing O2 sat could indicate hypoxia, so we want to pay attention for that. If there's no reason their sats should be going down, then that should be a big alert to us. And then, of course, watch for impending tension pneumo signs. Palpate for all these things, point tenderness, bony instability, nothing new when we start talking about all this. We do want to percuss for hyperresonance or dullness, so kind of a hollow sound which suggests increased air in the cavity, or a dullness which suggests blood in the cavity. And then you start auscultation, so adventitious lung sounds. We're looking for wheezing, rales, rhonchi, all of that stuff, stridor, and confirmation of lung sounds. Circulatory assessment, assessing the quality of pulse. That should help us determine the hemodynamic stability. If they've got a good solid radial pulse, we should, it should kind of give us an idea about where we're at. Clue you into the clinical findings of a cardiac tamponade. So review your findings. We're going to talk a little bit about it, but review your stuff from prior about your cardiac tamponade. JVD suggests increased intravenous pressure, so that can come from a couple of different things. It can be from tension pneumo, volume overload, right-sided heart failure or CHF, cardiac tamponade. Typically that's measured in a 45-degree semi-Fowler position. So now if you do have a collar on someone, it is going to be difficult to assess. So don't expect that you'll be able to see it real well. But a lack of JVD in supine patients, with other physical findings suggests a hypovolemic state. Auscultate the hearts. Note if the heart sounds are easily heard or muffled. Now, hopefully you'll remember that's one of the key pieces of finding a tamponade is those muffled heart tones. So, a couple of things to think about when you'll start needing to figure out, critically think your way through tension pneumo versus cardiac tamponade. Well, a tension pneumo is going to be about breath sounds, and cardiac tamponade is going to be about heart sounds. So remember that. If shock is suggested, it may not be from thorax, so it could be from other significant injuries. Transport decisions. Immediately life-threatening chest injuries that must be detected and managed during the primary survey. So all of these things have to be managed during our primary survey. Airway obstruction, bronchial disruption, diaphragmatic tear, esophageal injury, open pneumo, tension pneumo, hemothorax, flail chest, cardiac tamponade. And then we got a couple of things that could be identified in the secondary. But these are all things that we need to be able to recognize and know that we need to get out of there quick because this person needs something a lot more than us. History taking can be done en route. I've obtain your relevant patient info if you're able to. Questions about the event should focus on the mechanism of injury. So speed of the vehicle, or even how tall, or what the height was from where they fell. What safety equipment were they using? Were they seat belted in? Did they have a helmet on? Type of weapon used, if they were assaulted, the number of penetrating wounds, those type of things. So a secondary assessment includes a head-to-toe assessment. Once again, we want to check for injuries that may compromise ABCs. We're always going back to that primary survey. So remember, that secondary is going to hopefully point us to something that we might have missed in our primary. Obtain a full set of vitals, and then using your monitoring equipment with whatever you might have and whatever your protocols might say. Chest injury is isolated with limited mechanism of injury. The things we want to focus on is that isolated injury, as well as the complaint, and then the body region affected. So now if it's not just this limited mechanism of injury, like a stabbing or a shooting or whatever, then we want to do that head to toe. Some of the things we want to look for is ecchymosis, any other trauma. We want to identify all the wounds that we can. Note the location and extent. Assess the underlying systems. Make sure that we look at the front and the back as well. And remain alert for changes in the ability to maintain adequate respiration. So if they're getting tired or just unable to keep breathing, we need to be able to recognize that. If a significant trauma that is likely affecting the multiple systems, then we want to perform a full body scan. Determine the nature and extent of the thoracic injury. Inspect the region for deformities, which may reveal multiple rib fractures, crush injury, significant chest wall injury. Obtain or repeated assessments, so vital signs, oxygenation status, circulation or circulatory status, breath sounds, all of those things. Because when we're talking about thoracic, there's going to be a lot of things that can go wrong. So oxygenation is a big one. Circulation is a big one. Breath sounds. So if pneumothorax is suspected, the patient should be considered unstable. So we want to reassess every 5 minutes. Some of the things we want to look for is dyspnea. Is it getting worse? Is it getting better? Tachycardia, JVD development. We start looking for that pneumo to turn into a tension pneumo and to be prepared. And we want to maintain a high degree of suspicion during on-scene treatment and transport. All right, continuing on. Had to take a little break, get me an energy drink. This is my second one for today. So this episode is sponsored by Bang, Potent Brain and Body Fuel. So go out and get you some, or don't. Either way, emergency medical care management focuses on maintaining that airway, ensuring oxygenation and ventilation, and supporting circulatory status, of course. So really our ABCs is what we're talking about, right? So we're going to work on our ABCs and then understanding that we need to get them out of there as fast as possible. Airway management, same as any other trauma patient, with the exception we're going to use jaw thrust instead of a head tilt chin lift. So it's not that it's necessarily just at these chest trauma. They have a special way. We're just talking about with trauma patients, right? Trauma patients, we know if their C-spine's not cleared, then we are going to use a jaw thrust maneuver versus head tilt chin lift. Want to avoid nasal airways if signs of facial injury. If possible, we want to move on to endotracheal intubation instead. But if a possible tracheal injury, then we want to reconsider endotracheal intubation. So we want to use at that point, use the least invasive airway management possible. But the whole key is that we want to ensure oxygenation and ventilation, right? We want to make sure that we're getting the O2 to the cells, or to the red blood cells rather, breathing it in, getting it into the lungs, providing it to be onloaded and then offloaded, and all of those things that go on with an oxygenation and ventilation. That's the key component here. So by doing that, we're going to provide some high flow O2, whether that's with a non-rebreather or whether that's with a bag mask ventilation. And then ventilation also. So we'll provide assistance if needed. So if we're talking about adequate versus inadequate airway or respirations or ventilation or however you want to fill it in, then that's what we're going to do. So understand this though, positive pressure can mess up a pneumothorax, meaning making it worse. So if you have a simple pneumo or just a pneumothorax and you start positive pressurizing the cavity, you've now more than likely going to convert it into a tension pneumo. So be careful of that and understand that you're going to be pushing all of that air into that cavity. So it shouldn't be withheld, but carefully delivered. So we want to make sure that we're doing nice slow respirations. We want to make sure that we are seeing visible chest rise and fall without overinflation of the chest. Oops, that's not on my... Oh, there we go. So pharmacologic agents are limited in trauma management. Obviously, not much we're going to be able to do for them. Includes meds for the appropriate airway management. We've talked about that, right? And then meds for pain management. Narcotic, non-narcotic analgesics. So they may be limited by local protocols, short transport times, or even the clinical state of the patient. So depending upon your protocol, some say give this, some don't. If you have a short transport time, you may not have enough time to give someone some dope because you're messing around with your A, B's, and C's so much. Or in the event that they're hypotensive, and we all know, yeah, sure you guys remember every piece about pharmacology, we all remember that certain medications are not good for patients that are hypotensive. So that would rule them out. We'd not be able to give them. So some of the non-pharmaceutical approaches that we could do, splinting the injury, that's what we're hoping is going to help a little bit by splinting it so it's not constantly grating on each other. It's not causing more damage to soft tissue as well as vessels, nerves, all of that. Cold pack application, get that cold in there, help decrease some of the pain sensation. And then careful handling. You know, I think there's careful handling can be a pretty important piece that if we slowed things down a little bit, you know, that can help a lot. So the trauma centers transport to the appropriate facility. Trauma centers are going to be our first choice, especially with life-threatening injuries. They may not be readily available and they may be too distant. But we want to remember that principle of the golden hour or the golden period, the time during which the treatment of shock or traumatic injuries is most critical and potential for survival is best. We want to do whatever we need to do to get them to the right place in the right time. Let's talk about some injuries. Flail chest may result from a variety of blunt force mechanisms. So we're talking about, you know, a fall, obviously, motor vehicle crash, an assault, a lot of different things. Now, here's how, if you're wondering about these guys, things are serious, mortality rate ranges from about 50% to higher rates in those older than 60 years. So they're directly related to underlying and associated injuries. These are more likely to be mortal injuries if the patients are elderly, have 7 or more rib fractures, 3 or more associated injuries, present with shock, and have associated head trauma. Essentially, we're talking about a really sick person and they're old. So now we can understand why they are killing people. These things kill. It's not necessarily that. It just also has to do with all of this other trauma is really bad for them, obviously. So when we talk about a flailed chest, we're talking about 2 or more adjacent ribs fractured in 2 or more places. So a segment between the fracture sites becomes separate, and they separate from the chest wall. So essentially, as you can see here, you get this little free floating segment, right? Not good. Location and size affects the degree that the chest wall motion and air movement are impaired. So you can, even with a little bit more trauma, the most extreme version of this injury is this guy right here. So we see this is our sternum, right? You can get a flail sternum, and that's when the sternum is completely separate from the ribs. The downside about that is, well, there's a lot of them, but we see here with this flail segment, we have this one piece. So the ribs, we understand how the respiratory system works and the chest works. You have pressures. Negative and positive pressure. Flail segment, that paradoxical motion happens when it should be negatively pressurized. Essentially, it's not able to hold on to the structure and move with it. So what happens is you have that one side that is free floating and it moves. The downside for this flail sternum is it's completely separate from both sides. So now that guy is both sides. He's separate from both sides, and now he's moving on his own. So you've got a lot of issues with that. Talked about that. Underlying pressure causes paradoxical movement. May not be initially apparent, so that's why we got to get our hands on these guys and start looking around, taking shirts off, and looking at making sure everything is the way that it's supposed to be. So palpate the rib cage for fractures, for crepitus. Management may involve, so in the past, now depending on, I don't think anybody here has been in EMS a super long time. When I first got into EMS, I remember one of my first days checking an ambulance, and there were sandbags in the back compartment. I made a silly mistake and asked what sandbags were for, and I was told that's what they put on people's chest when they had a flail segment. I can't imagine how that felt. I mean, you got broken ribs as it is, and now some joker sticks 5 pounds of sand on top of your chest, and you're already having a hard time breathing. So it's went from that to then into bulky dressings. You guys probably heard that, the majority of you guys, unless you just got in a year or two ago into EMS. Things have started changing. But there's still discussion about it. So you still have one side of the camp that says you still bulk it, you still pad it, and dress it with bulky dressings. You have the other side that says you don't do that. You do not pad it with bulky dressings, and you just use positive pressure ventilation if needed. So that's what we're going to say. We're going to work off of this right here, which is management may involve, and see the word, may involve positive pressure ventilation. That's a lot to say, but that's just a little history on that idea. And what we're doing is just, so when we decide they have inadequate respirations, inadequate ventilations, that's when we step in with our positive pressure ventilation. So pulmonary contusions can also be caused by blunt force trauma. As you know what contusions are, we know that the same trauma that caused a flail segment can cause a pulmonary contusion. So you got implosion. Positive pressure from the trauma compresses gases in the lung, making it readily re-expand. And then inertial effects. Tissue density differences between larger bronchioles and alveoli cause them to accelerate and decelerate, creating tearing and hemorrhage. And then Spaulding effect is pressure waves from trauma disrupt the capillary alveolar membrane, causing hemorrhage. Pneumo or hemo. Pneumo being air, hemo being what? Go ahead, Mike Miller. You got it. Blood. Blood in the chest cavity may occur if bone fragments are driven into the body. So you see, pain may prevent adequate tidal volume. That's the same thing that goes on with rib fractures and all of that. That causes some of that atelectasis and causes the alveoli to become diminished, and essentially at times can actually become deflated. So what we're talking about is people aren't able to take a big deep breath because of the pain. So that limits the pulmonary system's ability to compensate for that flail segment. Management and assessment of this flail chest. Crepitus, tenderness, dissection. So some of the things, that's the palpation it may give you. And then auscultation, decreased or absent breath sounds on the affected side. You might find some tenderness. You would expect that, wouldn't you? Shallow breathing, tachycardia, signs and symptoms, hypoxia, hypercarbia, pain. So we would expect, if you remember how typically oxygen and CO2 are kind of inversely proportionate. So the higher the O2 goes, the lower the CO2 goes. So you have, fast breathing, you have the O2, you're exchanging more and more O2, and the CO2 is blowing off, so you have less and less CO2. So this is going to be the exact opposite. Slow or shallow, short, shallow breaths, probably barely moving past the dead space in the lungs. you're not going to be transferring much oxygen in there, and that CO2 is going to be building up, so you're going to have hypercarbia, right? And then, of course, pain. So poses a threat, makes sense to the ability to breathe, and should be treated immediately. So if you're able to intubate, positive pressure ventilation, that would be a good idea. Your goal is going to be at least 95% with supplemental O2 and positive pressure ventilations. So, as always, that magical number, 94 to 95. And then the use of continuous positive airway pressure up to endotracheal intubation may be needed for patients experiencing a reduced SpO2 with bag mask ventilation and supplemental O2. Some of the things that does, it helps the patient take full breaths, and then it improves oxygenation through improved ventilations. All right, moving on to rib fractures. Whoops. Most common thoracic injury. Part of the problem is the pain contributes to inadequate ventilation, self-splinting, atelectasis, pneumonia due to inadequate respiration. We're going to palpate. Some of the things we'll do, we want to palpate the chest for sub-Q air, subcutaneous emphysema. Think about Rice Krispies. If you haven't talked much about sub-Q air, but think about Rice Krispies being up underneath the skin. You kind of have a snap, crackle, pop, and you can kind of feel it, and it's just little air bubbles that have gotten trapped up underneath there. For me, it's always kind of gross. I never really liked it. It was interesting to see the first time, and then after that, it's just kind of weird. But it's something that happens, and we've got to be prepared for it. So, blunt trauma force to the thoracic cage may result in a rib fracture in one of three places: the point of impact, the edge of impact, or the posterior angle of the ribs. So, just so you know, ribs 4 through 9, those guys are the ones that are most commonly fractured. Let's see here. Rib fractures may indicate other associated injuries. So if you have a rib fracture 4 through 9, you might also have one of these injuries. You might have an aortic injury, a tracheobronchial injury, a pneumothorax, or a vascular injury. And then ribs 9 through 11, an intra-abdominal injury. And that's just kind of letting us know what those ribs are protecting. Those are all the structures that are behind it. So assessment, patients are going to report that pleuritic chest wall pain, very similar to whenever you're talking about someone that might have pleurisy. Also have some mild dyspnea. Exam may reveal chest wall tenderness, soft tissue injury, injury, crepitus, and then sub-Q air. If you've ever had a broken rib, this is the type of injury that psychologically can make you think you're dying. You can develop all kinds of chest pain, and you can't breathe, and it can really mess with you. It's a horrible injury to have, as opposed to multi-system trauma. It's not a big deal. But I'm just telling you, psychologically, you don't process it very well, and you can't get a breath in there because it hurts so bad, and you just think something bad is going on. So, assessment and management, ABCs, administer O2, gently splint the chest wall, and then if you're able to be a nice guy, give them a little dope so they will be able to take a big deep breath. That's one of the things that is very common with rib fractures. They will give, I think the last one I saw, one of my boys had, he got Tylenol with codeine, I believe, and the reason that they do that is not necessarily for the pain management of the rib injury. It's to decrease the pain sensation while they're breathing, so they're able to breathe and fill up their lungs and get that lung completely full and keep it expanded and all of that. Because otherwise, without that pain management, probably not going to happen. Hang on. So sternal fractures, the suspected fracture of the sternum should increase your index of suspicion for injuries to the underlying organs. So we know that if the sternum takes a really hard shot and is fractured, that but should give us an idea about the amount of energy that's transferred this way. So all of these organs here, so lungs, the great vessels, the heart, everything under here, that all took a pretty good shot too. So you could see everything from weird EKG rhythms, of course the chest pain and respiratory issues, a lot of different things going on. Assessment and management, so pain over the anterior part of the chest. You want to do some palpation, tenderness, deformity, crepitus, a lot of just basically decap BTLS and a little advanced because we're going to be looking for some Flel segments and things like that as well. Perform an ECG rhythm analysis. Remember when the heart gets struck like that, we'll learn something here in a sec, that when the heart gets struck, it can change the rhythm that the heart is in. So it's interesting that we deliver an electrical shock, but you can give electricity just through essentially a thump. We used to do a precordial thump, which delivered, I don't remember exactly how many joules of electricity whenever you had smacked somebody right over the heart. We stopped doing that. But in the old ACLS manuals, it equated, I believe it was 60 or 70 joules with getting the equivalent of getting kicked in the chest by a horse. So if you think about a steering wheel hitting somebody at, both parties are doing 50 miles an hour and hit each other head on, you now have 100 miles per hour worth of energy. Well, you can imagine the kind of energy that's transferred into the heart muscle. So it's going to do a lot of electrical things. Supportive treatment only, ABCs, manage associated injuries, and then analgesics. So one of the things you want to be thoughtful about, though, is if they do have some respiratory issues, we don't want to, when we say analgesics, we don't want to give enough dope or enough meds that it starts to suppress the respiratory drive. If you remember about opiates, one of their major side... hang on, I got to sneeze. Oh man, I'm sorry. One of the things about them that we need to remember about opiates is they can suppress the respiratory drive. So we don't want to give enough that starts happening. And we want to be thoughtful enough that if we see that, then either we stop using it, or we may even have to maybe you gave them way too much and you got to give them a little bit of Narcan just to get them back. Or you just start bagging them and you allow them to be comfy. Clavicle fracture is one of the most common fractures. I believe this is actually the most common fracture. Occurs most often in children falling on an outstretched hand. Cycling crashes, snowboarding, crush injuries to the chest. A lot of kids playing football and soccer are going to have these. So, assessment: patient will report pain in the shoulder, and this is one of the big parts. Is you'll see them holding their arm across the front of their body. They'll usually take care of splinting that themselves, self-splinting. Splint the fracture with a sling and swath. You should already know that. Simple pneumo, accumulation of air or gas in the pleural cavity. So the air enters in through a hole. We see this little hole right here. Causes a lung collapse on the affected side. Let's see. Yeah. Small pneumo, mild dyspnea, pleuritic chest pain, diminished or unequal breath sounds, hyperresonance. Now, there's been multiple car crashes I've been on that did not present with signs and symptoms of a pneumo, but by the time they'd been in the ER for an hour or two, they started developing some signs and symptoms. And the only way they even knew really that they had this pneumo was by, X-ray. Because it's very small and it takes quite a while to accumulate to where it becomes symptomatic. And then a larger pneumo, increasing dyspnea, signs of serious respiratory compromise, and hypoxia. So this is where some of those critical thinking skills come in, to where you know that they took enough of a blow that it could have caused a problem, that's always kind of in your mind while you're taking care of this patient, is that that they may have a developing pneumo coming upon. ABCs: conduct repeated assessments, rapid recognition. We're still talking about simple. Open occurs when a chest wall defect allows air into the thoracic space. So that results from, we're typically thinking about penetrating chest trauma. And what that does is kind of creates a link between the external environment, so the outside, and then the pleural space. That's created when negative pressure in the thoracic cavity draws air into the pleural space with each inspiration. Remember going back to your A&P and EMT basic or EMT curriculum where we learned about positive and negative pressure. So that's how that air is able to be drawn in. So with the increase in size, the lung loses the ability to expand. And then here's the real problem, is if the hole is larger than the glottis, the glottic opening, the air is more likely to enter chest wall than the trachea. So that's going to be a real problem, which then creates a sucking chest wound. That's not something that is good for people if you didn't know that. So we don't want to do that. Air moves in through the chest wound instead of the lung during respiration. And then it ends up turning into a collapsed lung. Doesn't have one here, but ends up turning into a collapsed lung because you have this ventilation and perfusion mismatch, VQ mismatch in the event. We will be talking about that later, so you'll see. We'll talk about VQ mismatch or perfusion to ventilation mismatch. See where we need to go here. So, pulmonary vasculature on involved side remains intact. The heart will continue to perfuse the collapsed lungs. Pneumothorax prevents ventilation, though, in which we know that will result in a couple of different things. One is hypoxia, right, because we're not bringing in the O2, and as well as hypercarbia, because we're not blowing off, we're not be able to get rid of those waste gases, and that's going to be a real problem. Chest physical assessment, chest wall defect. Might find an impaled object. You might have a sucking chest wound. You could have a bubbling wound. If the air, what happens if the air is forced out of the chest with positive expiration pressure, then you could have a bubbling wound. Of course, you can get some sub-Q air in the same type of patient. So, subcutaneous tissue of air moving in and out of the open wound. And the biggest thing we want to do, though, in this is to, focus our assessment on the possible presence of the pneumothorax. So, because of decreased ability to oxygenate and ventilate, signs and symptoms may include tachycardia, tachypnea, and restlessness. Once you start getting a shift, mediastinal shift, you start having some real issues, and this is all developing. So breath sounds start to decrease on the affected side. You want to treat immediately. So we're talking about an open pneumo here. So we want to convert it to a closed pneumo. Initially, you're probably going to do that with your hand when you walk up. You're initially just going to put your hand right over it, block that thing off until you're able to get either just some type of four-sided splinting thing that you'll tape on three sides, essentially a dressing that you'll tape on three sides. Or you might even have, like you see up top, you might have a commercial device that has a one-way valve that allows air out and doesn't allow air back in. So on the bottom one, where we're just going to put a dressing and tape it on three sides, what that's doing is allowing air to come out by leaving one side untaped. That is allowing air to come out and air to not go back in. Open pneumo doesn't usually progress to a tension pneumo, but it could happen from continued air accumulation. So we want to make sure that we are doing a good job at not allowing that air to come in. Tension pneumo. Here's the big daddy. Life-threatening condition from continued air accumulation. So that's one of the things that you should recognize is when we talked about I don't think I can get back there. Hang on. When we talked about this open, we said it doesn't usually progress because we're able to shut that down and not allow the air to continue to come in. So what happens here is you have this continued air accumulation within the intrapleural space. Whether maybe you're not able to control it, or maybe there was just so much air that got in there before they became a patient for you. But As air accumulates, pressure builds against the surrounding tissues. You get a couple of different things that go on there as it accumulates. Compresses the lung, which diminishes the ability to do a couple of things. One is, as we've talked about, oxygenate the blood, and two, its ability to eliminate CO2. Those are two really big things that the respiratory system needs to be able to do. Then the pressure causes that eventual lung collapse and the mediastinum to shift. That's when we start seeing some real issues, because now we have a collapsed lung, as well as the mediastinum starts moving over and starts affecting the cardiac output. So you get a little bit of shunting. You can have some right to left intrapulmonary shunting and hypoxia. You also have some cardiac output reduction from the heart and the vena cava, because those guys start getting compressed. And then you have a decreased venous return to the heart, which in turn reduces the preload. You remember the preload is what everything came back to the heart that encompasses the stretch, so that beginning of the contraction. Classic signs: absence of breath sounds on affected side, unequal chest rise, pulsus paradoxus, tachycardia, dysrhythmias, JVD, narrow pulse pressure, tracheal deviation. So remember, we've got several things. We have widening pulse pressures with like head injuries and things like that. We also have narrowing pulse pressures. So you're going to see, lots of different things. Tracheal deviation. The change, talk about tension pneumos, is induced by the tension pneumo. So the inability of blood to easily return to the heart from the venous system. So that increasing pressure within the thoracic cavity leads to the accumulation of blood within the great vessels. Now we're talking. Now, as you can probably imagine, if we're having that increasing pressure and accumulating blood within the great vessels, we may end up starting to see some JVD, right? So as the pressure is translated to the most superficial of these veins, they become distended with blood. So JVD is what we're kind of talking about here. But JVD also is usually a late sign of tension pneumo. So during a normal inspiration, you see typically you have negative pressure, which decreases the blood return. Preload and systolic blood pressure decrease. But in tension pneumo, the effect is magnified. So that's known as pulsus paradoxus. We mentioned that a second ago. So the radial pulse will be palpable with expiration and non-palpable on inspiration. So we covered pulsus paradoxus, which is kind of a weird thought process, but remember, radial pulse will be palpable with expiration, non-palpable on inspiration. Moving down to jugular veins. So the jugular veins are considered distended when engorged to about 1 to 2 centimeters above the clavicle. So it pretty much stands out as to what that looks like. Trachea palpation or visualization may show a trachea deviation away from the affected side, and it starts to shift. You get a tracheal shift, and it's trying to move to the unaffected side, so it's able to focus on getting as much air in as possible. So we want to watch for all of these kind of things, the breath sounds and chest pain, all of that, because air accumulation in the pleural space decreases the lung volume, diminishes breath sounds during auscultation. So there's a lot of just different things that are going on when we talk about findings about what we may see. They may have diminished breath sounds, pleuritic chest pain and dyspnea. Hypotension is a late finding also. And it's because the mediastinal shift, the mediastinum has shifted so much over from all of the pressure, from all the tension, that now it's starting to compress everything, so it actually takes a little while for that to happen. High flow O2, inspect the chest, cover the wounds, allow air to escape by lifting one corner of the dressing if signs of tension are present. And then in the event that if elevated pressure relief is needed, then we're going to do a needle decompression. And this curriculum does not have that much information about that, but we're going to be doing that in the lab, obviously. Now, it's important to know that the needle that is improperly placed, it can cause hemorrhage, or an injury to the lung. So we want to make sure that we're doing a good job. But the flip side is a failure to treat that tension pneumo that patient will end up progressing into a full arrest. Hemo, that potential space between the parietal and visceral pleura is violated. It starts filling up with blood, commonly caused by the lung parenchyma tearing. So you get that tearing of the lung that, if I remember correctly, I think it's parenchyma. I can't remember how you pronounce it. But it's around the alveoli area, and it'll start to fill up with blood, which is not good, as you can imagine. Penetrating wound, puncturing the heart or major vessels, blunt trauma. Hemo, blood and air hemopneumo, blood and air in the pleural space. And then massive hemo, accumulation of more than 1,500 mils of blood within the pleura. Ventilatory insufficiency, hypovolemic shock, those are some signs and symptoms we might see. Assessment management, findings that differentiate from other injuries. So lack of tracheal deviation, because there's not an injury there that's causing, that shift. Possible hemoptysis, dullness on percussion, dullness rather than the hyperresonance. You have hyporesonance because it's filled with blood, so it's going to be dull. Flat neck veins. Supportive care, giving them some IVs and some fluids. Want to keep their depending on how you roll on your protocols, either probably permissive hypotension, so like 90 to 100, or maybe you work off a system to where you use MAP, your mean arterial pressure, and typically somewhere around 60, 65 is where I think most places are using. Pulmonary contusion, alveolar and capillary damage results from the lung tissue compression against the chest wall. Nothing different here than what you've already learned. Local surfactant in alveoli is diluted, which causes atelectasis. So they start failing, and then the delivery O2 is reduced, causing hypoxia, and then the attempt to shunt blood from the injury further away worsens the hypoxia. So hypoxia, CO retention may cause, you can see here, those different signs and symptoms: respiratory distress, dyspnea, tachypnea. Auscultation, look just about everything, right? Wheezes, rhonchi, crackles, diminished lung sounds. Tamponade, excessive fluid in the pericardial sac. This is one of the things that I talked about earlier, that we need to be able to differentiate cardiac tamponade and tension pneumo. So you get a few of the same signs and symptoms: compression of the heart, decreased cardiac output. So if you think about decreased cardiac output, what's going on? Essentially, the output of the heart muscle is decreasing, so what we can expect is some decreased perfusion status, right? So we expect a blood pressure, probably a bad blood pressure. We'd expect some color changes in the skin, those type of things. Size of the pericardium perforation is, now we're talking about how it's determined by, the hemodynamic effects determined by. So size of the perforation within the pericardium, the rate of hemorrhage, and then the chamber of the heart involved. Most often the right ventricle has been penetrated. So these are most commonly caused by penetrating wounds, but can be from blunt injuries. They can occur in both medical and trauma patients. Medical, you got the inflammatory processes cause slow fluid collection within the pericardial sac, and you can get anywhere from 1,000 to 1,500 mils can accumulate. So it doesn't always have to be a trauma patient. You can get a tamponade just from a medical patient. But with a trauma patient, bleeding is rapid, with blood loss quickly collecting between the visceral and parietal pericardium. So as little as 50 mils of blood can cause the cardiac output reduction. Continued bleeding increases pressure in the pericardium, and as you can see, the atria and vena cava, they start to compress. Those are probably the more pliable structures there. So you get a lot of different things, man. Preload delivery is drastically reduced. So by preload being reduced, we also have a decreased or diminished stroke volume, right? The heart tries to compensate by increasing the heart rate. We've talked about, cardiac output. Heart rate times stroke volume equals cardiac output. So to stay at the same cardiac output, if one goes down, the other has to go up, right? So if the heart starts slowing down, then you've got to have a bigger stroke volume to equal the same amount of cardiac output, because the body is we're kind of wired for a pretty specific amount of cardiac output. So what happens is the heart will increase the heart rate, and then continued bleeding restricts the preload and diastolic filling even more. Pressure also reduces myocardium perfusion, so now we're starting to get some damage to the heart, and then it leads to hypotension. So that's not good. So you heard before we talked about Cushing's triad, right? Remember what that was, which was what? Think about what that is for a second. Yep, you're right. So it is hypertension, bradycardia, and an altered respiratory pattern, right? Now we're going to talk about Beck's triad. So that is a cardiac thing. So here's what we have with Beck's triad: muffled heart tones, hypotension, and JVD. So about somewhere in the neighborhood of 10 to 40% will have Beck's triad of these cardiac tamponade patients. Now you'll see this is probably just a little bit early for you, but another classic finding is electrical alternans in an ECG strip, and essentially what that is within the heart itself, it's going from a low voltage to high voltage. So when you look at your, I don't have it, it's in the EKG thing. Well, I have a slide for it, but it has, when you think about all the little blips, it has a little blip and then it has a big blip. It may not rotate one to one, but it has little ones and big ones all mixed in there sporadically. So that's the electronic alternans. It just alternates the current of how much output there is. Findings typical of shock. So diaphoresis, dyspnea, cyanosis, altered mental state, all those kind of things. Assessment and management. Honestly, assessment and management is going to be pretty simple. Recognize, manage ABCs, and go. You need to give, these people are short on diesel. You need to be moving or calling a helicopter. Assessing and managing ABCs, getting an IV, providing a rapid fluid bolus, administering IV fluids, rapidly transferring to trauma center for pericardiocentesis, which is this right here. So what happens is the doctors go in, insert a big old needle in there and drain that thing out, and then allow it to heal back up. We're not going to do that. Myocardial contusion. I think we're hopefully getting close to wrapping this up. So sudden deceleration of the chest wall. I think we've really went over the big interventions and the big things. So we're probably kind of just shoot through this pretty quick. But myocardial contusion, we know contusion basically being a bruise, right? Kind of a hematoma. Sudden deceleration of the chest wall from speeds greater than 20 to 35 miles an hour cause a collision of the heart to the posterior aspect of the sternum. So it's characterized by some local tissue contusion, some edema, some cellular damage within the myocardium. So you might have some ectopic activity. Now we're talking about EKG stuff. Reentry pathways, dysrhythmias. You're not going to know that if you don't know what any of that stuff is. So doesn't really matter to go over it right now. But as you can imagine, often an abnormal ECG because you just got punched in the heart pretty hard and you're going to see some weird stuff. It's not uncommon. Supportive care, fluid resuscitation. And then, as you see down here, we'll talk about that, treatment of the dysrhythmias. Myocardial rupture, how's that sound? That doesn't sound very healthy. An acute perforation of the ventricles, atria, intraventricular septum, intraatrial septum, or all the little pieces in there, the chordae tendineae, the papillary muscles, the valves, all that. So typically that's caused by severe blunt force trauma or penetration trauma from a foreign object propelled into the heart. So as you can imagine, that does not sound really good. Might have a tamponade, signs and symptoms of tamponade, acute pulmonary edema. Supportive care, rapid transport, right? Commodio cordis. So I said we would talk about something in getting struck in the heart. That's what this is. Cardiac arrest caused by a direct blow to the thorax during a critical stage in the heart's repolarization period. So essentially, if you've ever been at that football game where a young kid got hit and then had to be defibrillated because he went into full arrest, that's probably what happened. So essentially, right over their heart, they were struck by something, either a baseball or a helmet or something, and it happened to be at this very specific point in the repolarization period of a heartbeat, and it knocks most people into VFib. So that's why it's really big now that we are keeping AEDs at these football games. So signs and symptoms: unresponsiveness, apneic, no pulse, cyanotic, seizures. Traumatic aortic disruption. So dissection or rupture of the aorta, usually caused by blunt trauma from crashes and falls. 1 in 5 deaths from blunt trauma include transection of the aorta. Quite a few, huh? Fixed points by shearing forces, talking about the aorta getting torn up. Let's see, anything. Great vessel injury. Presentation may include pain, pallor, paresthesis, pulselessness, paralysis, 5 Ps. Hypovolemic shock, hemothorax, cardiac tamponade. IVs, treat the pericardial tamponade immediately. Diaphragmatic injuries occurs in a small percentage of trauma. Most occur on the left side. There's your 3 phases. Tension gastrothorax, herniation of the abdominal contents in the thoracic cavity. Ugh, doesn't sound good. You see everything over and up. Esophageal rapidly fatal injury in the GI system. I'm going to let you guys read through these. I don't think there's much to talk about. Traumatic asphyxia, so induced by traumatic injury that forcefully compresses the thoracic cavity. It can be done by anything from a car sitting on top of somebody to, if they were in a ditch and it caved in on them or whatever. A lot of weird bruising patterns because all those vessels burst, petechiae. So you see all of these. These are all the little capillaries and everything that burst here. That's what they'll do. They'll look in the eyes as well. See that? Cervical spine precautions. Get some fluids. High flow O2. Whew. Okay. Got that one at about an hour. So once again, make sure when you come to lab that you're going to be squared away on needle decompression. Obviously your airway stuff, but we're going to do needle decompression in lab, so pay attention to that. Make sure you know your landmarks. Make sure you know your signs and symptoms, because on this written test, that's the stuff you're going to be tested pretty heavily on, is who has a pneumo and what am I going to do about it. So recognizing it, and then what am I going to do, as well as some of the processes of oxygen versus CO2 and the onloading and offloading and how all of that works, so we know that it's important that all of that works properly. All right, that is another exciting edition of So You Want to Be a Paramedic, and I will catch you guys next time.